Hello and welcome. While the number of coronavirus cases continue to rise across the country, the one or two figures that people are taking some comfort in is the number of patients who are either in intensive care unit, which is about 2.25% across, according to the government of India, and about less than 5% in critical care. And the number of patients on ventilators, which was at one time seen as a very critical indicator of the state of patients or the progression of the disease, is very low, actually in single digits across the country. However, the number of patients under ventilators and intensive care unit in the city of Mumbai, which of course now is the hotspot of the hotspot, is showing at abnormally high levels. For instance, the Mumbai Municipal Corporation has put out figures saying there's a 72% of the ventilators that have been allocated presumably to COVID cases are being used, and about 99% of intensive care units are being utilized presently. So the figures, of course, can be have to be dive deeper into. But let's try and get a larger sense of what's happening right now from two specialists and senior doctors at the front lines. I'm joined now by Dr. Farah Ingle, Senior Consultant, Internal Medicine at Fortis Network, and Hiranandani. Dr. Bharat G Jagiasi, Head of Critical Care at Reliance Hospital. Both are based in Navi Mumbai. Thank you both for joining us. Dr. Ingle, let me go with you first. So your takeaways from what you've been seeing in the last couple of weeks and the progression of the disease, particularly amongst COVID-19 patients.
Yeah, good evening, and thank you for calling me again. See, basically, what you said, I completely agree with you. Now, Mumbai is a metropolitan city. Okay, the population density is also very high in Mumbai, and all the major metropolitan cities all over the world has large number of cases. And why Mumbai more so is because now I can take a classic example here of Dharavi. Now, Dharavi is Asia's largest slum, and it is in the world the most densely populated slum. Now, here in Dharavi, we have people who are not from Mumbai in particular, but have come and settled from outside. And if you see, it's a distance of about 1.25 square kilometer or so, but the population is around 7 to 9 lakhs, I think. So you just imagine how they must be accommodating themselves. In a single room of maybe 10 by 10 or 10 by 12, there are about 10 to 12 people staying. So social distance has gone for a toss, okay? And even they don't have attached toilets and washrooms or bathrooms with them. So they use the common ones. So again,
right.
Now this virus gets spread. It is excreted in the stools also. And it can remain alive for up to a month, maybe for 4 to 6 weeks. So that is, and once the infected patient uses the washroom, the toilet, they should flush it out properly, and the other person should not ideally go and use it for another 1 to 2 hours, which is not possible. So I think that is the reason no social distancing, no personal hygiene that much in the slums. And then these people are into trade. They have the leather trade, they have the textiles, they have the pottery, and then all the highly people from good socioeconomic status go and visit their shops. And that is how I think it must have got transmitted.
Right, so that explains the high number of cases.
Yes.
What explains the high number of cases going into intensive care, Dr. Ingle?
See, that's, as you said, actually 75 to 80% of cases are asymptomatic or mild. 15% of cases actually are serious, and 5% of them only are critical. So maybe because I know then different strains of viruses also, which we are not yet very clear about. But then, like what you said, initially there were high number of serious cases, but now the figure has come down. So it is at par with any other major city across the world. It's not that high. Initially,
Okay.
Of course, it was high. Yeah.
Right. Okay, Dr. Jagiasi, how are you seeing the patients that are coming to you or in your hospital? I'm talking about COVID-19, of course. And do these numbers that we are seeing from the BMC match with what you're seeing in your hospital?
See, as of now, what we have seen is there are around 250 or 300 cases admitted under my care, and around 50, 60 are passed through the ICUs, and there are certain number on the ventilators. So as Dr. Ingle said, it's right. There are number of cases. So you need to understand the definition. I think there was confusion when we were narrating the figures by the national authorities. Intensive care patient and critical care patient remains the same. It's the same terminology. It's I mean, the
Right.
meaning is same, terminology is different. So you can't have the different figures for the intensive care and different figures for the critical care. So what they must be thinking is there's a certain set of patients who require just oxygen and they do away with it, or we can call it as a high flow nasal cannula or non-invasive ventilation. So those are kindly, I would say they are still severe, but they must have said those are moderately severe. And there's a certain case who require a full-blown ventilator. And so we have those kind of cases along with us. So the percentage-wise, as Dr. Ingle rightly said, somewhere around 10 to 15% cases need intensive care. But the severe are the one who I would grade requires a ventilator. Those are around 3% or 2.5% of the cases who requires a ventilator. And the problem here is the average ventilation time is pretty very long. Suppose one of my patient who goes on the ventilator, minimum days of ventilation is 14 days and it could extend to the 25 to 30 days, which really involved by one ventilator for a long period of time, and which is not true in other sets of disease where patient is ventilator free in 5 to 7 days. Here my ventilator is occupied for a longer time, and this is where the acute shortage of ventilator comes in play. So the figures, what you have been propagating, I think there's some set of confusion. Someone who has projected the figures, these are not kind of the real ones. Or maybe I wouldn't say the real one. No one would project those kind of figures. There's some problem in quoting the numbers or understanding the terminology.
Right. Okay. So let's put the numbers aside. I mean, the idea is not to debate the numbers. I mean, I'm trying to understand from your own experience. So you said you've had about 250 patients from start, or is it in the last or currently?
No, this is a total number. No, it's not the number at this moment. These are the total number of patients admitted under my care 250, and around 170, 180 has been discharged out of those, and 80 or 85 left under my care at this
already.
moment.
Okay. Now, of these, you said only a few are in ventilator right now?
Yeah, few are on ventilator. So percentage of ventilator, if you ask me, around 2.5% of the cases goes on the ventilator.
Right. So that figure is somewhat accurate.
That is amongst my institute. I don't know what is happening at the other institute. So in my
sure. We'll come to that. So now amongst these patients, now you're also saying that most of these patients have been under ventilator for more than 14 days or at least 14 days.
Yeah, that's the average median time. That is across the globe. The recovery is very slow amongst these patients. So the average ventilation time, if someone recovers, obviously somewhere around 10 to 14 days amongst these patients.
Right. And how many ventilators do you have in your hospital?
That would be difficult to quote because those are with the stats with the hospital, but we have enough, I would say. Yeah.
Right. Okay. So, Dr. Ingle, how is it in your hospital? I mean, or others that you know of, the number of patients who are on ventilator versus number of patients who are, let's say, in the general ward, but also being treated for COVID-19?
Yeah, as Dr. Bharat has rightly said, see, the number of patients on ventilator are at par with any statistics anywhere else. It's not that we have too many, and it varies from person to person as to how many number of days they are on ventilator, but usually it takes 2 to 3 weeks once they are on ventilator. Now, ours is a TCHC. So we have mostly mild to moderate patients in our hospital, but you never know, patient just deteriorates like fast in a day also, they may deteriorate. And those patients who require ventilator, in-house patients, then we put them on ventilators. We don't accept serious patients from outside just because ours is not a COVID hospital. So like what Dr. Bharat said, it's around 2 to 3%, and that figure matches the figure anywhere else. And it is not like Mumbai patients are more on ventilator, or Mumbai the patients are not recovering. Many of them are recovering. We are following the standard protocol and they are responding as they are doing anywhere else. Yeah.
Right. Okay. So let's take a step back and let's look at critical care or intensive care unit, right? So if you're in intensive care, it is not necessary that you're under ventilator. So how is the percentage or proportion then?
So then
it comes to around 5%.
Yeah, ma'am.
Please.
You're right. It's the
same. You go ahead.
I was quoting the same figure, 5% somewhere around.
Yeah. Yes. Yeah. Right.
Right. So, and the 5% is intensive care. So how are you, I mean, what is the periodicity? So when people go into an intensive care unit, and we're only talking about COVID-19 patients, how long are they usually there from your experience?
See, as we said, recovery takes pretty long. So the average stay in ICU somewhere around 10 to 12 days. And if someone gets ventilated, then the stay is prolonged. And the percentage of ventilator, though ours is matching with what the society has it, but obviously there are different sets, different demographics. Sure. If I have more of diabetic, more of 60 year and up, 65 year and above coming with me, So those are the risk factors associated with the patient going on the ventilators. We have very few patients who have been young and being on the ventilator, but it all depends on the demographic. There have been institutes where there are more patients on the ventilators, but the reason being is they had more of the older patients, more of the diabetic patients, and more of the heart patients along with them.
Right, right. So, okay, now let me ask you a slightly different question. Now, don't give me numbers, but give me percentages if you can, Dr. Bharat. In your hospital, so suppose let's say there are 10 beds for intensive care unit. How many are being occupied by COVID patients, and how many are being occupied by non-COVID patients who may have been there much earlier?
No, now see, as the ma'am rightly said, we have been the COVID unit. So we have certain assigned beds of the ventilator or assigned beds of the hospital for the COVID patients. So all those beds are occupied by the COVID patients, and there's no bed left in that unit for the non-COVID patients.
But in the hospital overall, you don't have any non-COVID patient who is also in intensive care?
We have few beds for the non-COVID patients as well, but the occupancy over there is not there because I think in this era, people are not willing to come to the hospital for the other complaints. So it's just that is the reason those beds are lying vacant. But whatever number has been allotted for the COVID patients, all those are almost occupied. Yeah.
Right. So, Dr. Ingles, let me put the same question to you. The reason I'm asking this is that, you know, in normal times, hospitals are full in this country, and people are in intensive care, people are getting ventilated for all kinds of problems. So, I mean, what is that load that you're seeing at this point, particularly on critical care units, apart from COVID?
See, as Dr. Bharat has rightly said, in this period of lockdown, people are not supposed to move out of their house because of unnecessarily, except for the urgent work. And what I have seen is because we are staying indoors, most of the communicable diseases, the incidence has come down. And of course, there are patients, but then like there are not many patients, maybe because of fear, they are not coming out. And we are not doing elective surgeries. Most of the like surgical ICUs, we have post-op patients. So elective surgeries, we are not doing this season. Actually, more concentration is on COVID. That does not mean that we are not accepting non-COVID patients or we are neglecting them. But the overall reporting from non-COVID patient is comparatively less. It's only the emergencies that we are taking. So we have both the COVID and we have started with non-COVID work also. But everywhere else also, the non-COVID work is much less. It's only the emergencies that are coming. And maybe because of this lockdown, maybe because of the social distancing, maybe because we are using the mask, the incidence of infectious diseases, I feel, has come down dramatically. So that is why maybe those patients are not that much coming out and they're not reporting to us because incidence itself has come down.
Right, and that's very interesting, Dr. Ingle. So can you give us an illustration of an infectious disease that someone may not be getting now, but may have been getting earlier because they're, adopting all these precautions?
See, all sorts of communicable diseases, basically, which are transmitted through droplets, that is the respiratory illnesses. The other, because people are not going out, they're having the food inside the house. So maybe those problems, the gastrointestinal problems because of eating at the restaurants, the hotels, outside food, that also is less. So gastroenteritis cases, the respiratory problems, the cough, cold, coryza, and influenza-like illnesses, all those have come down.
Patients who are coming into critical care, right? We're not talking about just patients who are coming to your hospital.
Yeah, that's true. But then those patients also sometimes get critical because of the infection. If the infection spreads everywhere, they land in sepsis, multi-organ problems, and so on. Not all of them, but now even the diabetics, they are taking extra care of themselves. Now, those patients who become serious usually are the elderly patients, those who are diabetics, who have cardiovascular problems, hypertensive. Now, they are also taking good care of themselves, not exposing themselves, taking the medicines on time, following consultation with the doctors. They're keeping the problems under control, maybe because of extra fear they have. So they are not getting that serious. Yeah.
Right, and that's a good thing to hear. And I'm assuming that the other kinds of cases you're not getting much is accidents.
Yeah, accidents also because nobody's there on the road to drive that much. Yeah, that many vehicles are not there on the roads. That's true.
Is that your experience as well, Dr. Jagiasi? So some categories of
She rightly concluded. Mainly, I would say the main because everyone is locked down, sitting at home. So you have enough time to look after yourselves. Everyone is taking medications on time. They are not missing the doses of the medication, which would routinely happen when we are busy with the work. and outing has gone, so outside food is gone, so incidences of food poisoning is really gone down. I would just like add one more thing. Air is more purified now outside because pollution level is really come down. So the cases who are really coming to the intensive care were the acute exacerbation of asthma or the chronic obstructive pulmonary disease. They were the one who were taking a major bite of the ventilator. So all those numbers have come down because air is more purified. There's no more exacerbation, not because of polluted air, and neither because of polluted air and not because of the infections.
And these you're seeing a dramatic difference between, let's say, January, February, and March, April, or April, May.
Yeah, it's a very big difference. I mean, what we are seeing is the amount of the non-COVID patients have come down significantly. Whatever you take it as a pulmonary disease or cardiovascular disease or abdominal disease, everything has come down.
And this is not because, for instance, I mean, we see reports constantly, and my own colleagues tell me that people are trying to get admission into hospitals but are not able to get. You're saying that fundamentally the disease profile, at least for now, has changed.
No, for the normal non-COVID area, I think there are enough beds available everywhere, because though the hospital has been assigned just 20% of the beds in the non-COVID area as per the new regulations of the government,
right.
even 20% beds are lying vacant. I don't think occupying those 20% beds is a problem anywhere in this India, at least.
Right. Right. Okay. So last couple of questions. Dr. Ingle, let me begin with you. So one of the, I was speaking to Dr. Srinath Reddy of the Public Health Foundation of India, and I was asking him, what's the one figure that you would look at to understand or to convey what is our grasp of this situation in terms of fighting back with coronavirus. So, and his point was that the only data point that matters is deaths per million, or DPM. Or essentially how many people are dying. So what's your current experience on that score, Dr. Ingle? Are we doing well? Are we doing fine?
We are doing really fine, I can say, because the number of deaths have come down now. See, because initially the mortality was really high in Mumbai, if I talk of, it was around 7.2 something. It has now come down to 2.9 to 3%. So we are doing well. We are at par. And now people have got used to that. Like, I think there's a sort of, maybe, but I can't say exactly, herd immunity. But then people are getting, maybe many of them are already infected because they are asymptomatic. They don't come to us. And those people actually are not very infective to the society, but they may be helping indirectly in developing the immunity in the society. And the people are responding. So we are at par as far as mortality is concerned. But I don't think the problem is going to go away that easily. I think it will stay. We have to continue staying with the problem. It may be like the HIV patients, the measles patients, the chickenpox and other viral illnesses, which comes in crops, may be seasonal. It may stay. And vaccine also, it's not seen in near future. It may take 1.5 years. So the problem is going to stay. But then over a period of months, I can say it's nearly 6 months since December, the problem has started in China. And we have experiences from all over the world, and we have learned which medicines are acting better. So we have come to, in a way, better treat the patient now with little experiences from all over the world, and we are getting better results also. So the mortality definitely has come down.
Right. And Dr. Jagiasi, what's your sense on mortality? How are we doing? What's your own experience? Also, in the mortality that we are seeing, any more insights about where the incidence is higher or what demographic?
No, mortality has come down. I agree with it, but my explanation of mortality coming down is different from what Dr. Ingle says. But I would say that we are lucky we were not the initial one to have the disease. So we had the experience of China, we had the experience of Italy, we had the experience of NHS, and we were talking to our colleagues across the globe. So the understanding of disease, understanding of the per se COVID-19 is better amongst the critical care specialists. So what we are doing initially, or what we do for the normal patient, is kind of a different disease altogether. So initially we thought it's more of a pneumonia, but now everyone has agreed it's more of a thrombosis, hypercoagulous trait. So treatment is now different what it was initially. So now we have learned to manage the disease in a different way, and mortality significantly come down, even if the survival from the ventilator is obviously better in terms of what the global authority had initially. So the unfortunate one to have the crisis earlier on. So we didn't know exactly what it is. Now we have understood and we know how to treat it in a particular manner. So this is what is helping us.
Right, and you're also the Joint Secretary of the Indian Society of Critical Care Medicine. So, what are the kind of notes that you and your colleagues are exchanging right now?
So there are, as I said, there are the regular webinars happening and we have involved all our friends from the US, Italy, UK. Understanding how the disease is better, we initially, maybe 2 months back, we used to ask them what exactly is happening around, and they had those postmortem reports. So the treatment has varied. Initially, what they were doing at that moment, what we are doing now is really a different treatment, and we have different approach altogether towards the patient, and that is what is helping us. And so this is what the discussion goes on always. It's a dynamic field because it's a new thing. So every day something new comes up, and it helps us a lot.
Right. Last question, Dr. Ingle. So in the mortality or in the deaths that we've seen, any trends, any common factors in terms of, I know I've seen the data on age profile and so on, but any other insights that you have from the mortality that we've seen so far? Yeah, Dr. Ingle, the question's for you.
Okay, it's for me. So sorry. See, basically, as Dr. Bharat has already said, that initially we thought that it's a respiratory illness. But over a period of time and from data coming all over, now we have come to know that it's not completely respiratory illness. There are thromboembolic phenomena involved. And as he said, over a period of maybe 5-6 months, we have evolved and we come to know what is the pathophysiology, and we are treating accordingly. So we have started with a treatment protocol based on all the experiences from all over the world, and that is why we are getting better results. I completely agree with him, and that is what we are also seeing. When we do the scans, we find the typical findings. When we do the lab tests, we come to know, like, they have high D dimers, they have high fibrinogen level, FTP level is high, CRP is high. So there's inflammation all over. There's thromboembolic phenomenon that is involving the patients all over. So that those are the reasons, and that is also the reason for mortality. So accordingly, now we have come to understand the pathophysiology better. That is why we are able to treat it better now. And we have formed a protocol accordingly, and that is why the patients are responding better.
Right. We've run out of time. Yeah, go ahead.
Question, yeah. Among the risks, what you're asking is, apart from the normal, what is more important is, I think it's not very much aware of, obesity is the number one risk factor. Right. It's more of a risk factor more than the diabetes and hypertension. So if you want me to add on to something, if you want me to add on something to the risk factors, obesity is among the highest risk factor. This is what we are getting the information from across the globe. Yeah.
Okay, great. Wonderful. Thank you both for joining me. And like always, I wish you all the best in this fight against the coronavirus. And I do hope to connect with you soon and get your insights. Thank you very much for joining me.
Thank you so much. Thank you.